The recent study published in JAMA Network Open confirms what many in public health have feared for years. The maternal health crisis in the United States is not just persisting, it is deepening. Between 2018 and 2022, the rate of pregnancy-related deaths in the U.S. surged nearly 28%, with sharp disparities not only by race and ethnicity, but also across state lines. The data, which draws on 4 years of statistics from the CDC, paints a grim picture of a country where geography and identity can drastically alter a person's odds of surviving pregnancy. At its peak in 2021, the rate of pregnancy-related deaths climbed to 44.1 per 100,000 live births, before dipping slightly in 2022. Even after that decline, the 2022 figure, 32.6 deaths per 100,000, is still significantly higher than the 2018 baseline of 25.3. Over 6,000 women died from causes related to pregnancy in those 4 years. While the study did not directly determine the causes behind the surge, the COVID-19 pandemic is widely suspected of exacerbating an already strained maternal health infrastructure. The virus didn't just impact individuals, it disrupted systems of care, overwhelmed hospitals, and deepened long-standing inequities in access and outcomes. The variation by state is staggering and should not be dismissed as mere coincidence. Alabama and Mississippi posted the highest death rates, 59.7 and 58.2 per 100,000 births, respectively, while California had the lowest at just 18.5. These numbers are not just statistics, they are the consequences of state-level policy failures. States that have invested in Medicaid expansion, broader access to prenatal and postpartum care, and racial equity in health services tend to fare better. Meanwhile, states that have neglected these areas continue to suffer unacceptable levels of maternal mortality. These disparities are not accidental, they are systemic and predictable. The burden is not shared equally. American Indian and Alaska Native women had a pregnancy-related death rate nearly 4 times higher than that of white women. Black women faced a rate almost 3 times as high. These figures speak to more than just access. They reflect deeply embedded racial biases in the healthcare system, socioeconomic instability, and gaps in culturally competent care. Despite growing awareness of these issues, the fact that the disparities persist, and in some cases worsen, demonstrates a stunning failure of both public policy and healthcare delivery. One of the most haunting findings in the study is the number of deaths that occur well after delivery. Nearly 1,900 women died during the late maternal death period, defined as more than 42 days, but less than a year after the pregnancy ends. This phase, often overlooked, is where the healthcare system frequently loses track of mothers. Transitioning from obstetric to primary care remains poorly coordinated, especially for women in marginalized communities. These late maternal deaths are not just oversights, they are warnings about the blind spots in how the U.S. handles postpartum health. Cardiovascular disease remains the leading cause of pregnancy-related deaths, but it's far from the only one. The study also found significant contributions from cancer, mental health issues, substance use, and behavioral disorders, conditions that highlight how maternal health is deeply intertwined with broader issues of chronic disease management, mental health access, and addiction treatment. These are not isolated problems. They are the cascading effects of fragmented care systems and insufficient investment in women's health across the board. The United States continues to hold the dubious distinction of having the highest maternal mortality rate among high-income nations. That is not a failure of medicine, but a failure of governance, equity, and national priorities. Wealth alone has not protected American mothers. In fact, the trends suggest that inequality, rather than resources, defines the American experience of childbirth. This isn't just a medical crisis, it's a moral one. The data should serve as a call to action, not only for lawmakers and healthcare providers, but for society at large. That nearly 2,700 deaths could have been prevented if all states performed, as well as California, is not a footnote, it is a national shame. The solution is not elusive. Consistent investment in maternal health infrastructure, extended Medicaid coverage postpartum, culturally competent care, and aggressive intervention in underserved communities. These are achievable goals, but they require political will and long-term commitment. This crisis is not abstract. It is the erosion of trust in a system that promises care but too often delivers neglect. Until the U.S. treats maternal health with the urgency it deserves, more women will continue to die from preventable complications, and those deaths will fall most heavily on the shoulders of the vulnerable. That is the cost of inaction, and it is far too high.